Hello, and welcome to Talks with Docs, a service of the Lancaster County Medical Society. I'm Dr. Dale Michels, a family physician here in Lincoln, and I'm your host today. Today we have with us Dr. Les Spry, who's a nephrologist here in Lincoln, and Dr. Spry and I are going to talk a little bit about chronic kidney disease, which is one of the things that unfortunately we seem to be seeing more and more, partly with the aging of our population, partly with the disease processes that are coming on. So, Dr. Spry, welcome, and let's talk a little bit about how often chronic kidney disease, I know there are various phases of it, but again, it's a fairly common sort of illness that we're seeing more of, I think, in my practice at least.
Yeah, thanks, Dale. Yeah, it's nice to be here. Yes, it turns out that the incidence of chronic kidney disease just in the last 10 years has increased. There was a study done by the federal government that's called NHANES, and about 10 years ago, 10% of the population was found to be at risk or have chronic kidney disease, and that number was just recently updated to 13% of the population. So that this is the adult population. And so about 26 to 30 million individuals in the United States today have chronic kidney disease out there. And so we've been currently trying to seek out those people who are at risk for their chronic kidney disease.
Well, let's talk a little bit about that at-risk sort of thing. You know, none of us like to think of ourselves of any higher risk for anything. And, you know, when you and I were younger, we thought we were invincible. As we've gotten a little older, it may not be the case so much. But let's talk about that at-risk population. Who are those people out there that are at risk? And then we'll talk about what happens if they don't take care of themselves.
Well, kidney disease is a silent disease, and so there is really no way. You don't come in with your kidneys hurting, for example. Well, you do in certain circumstances, but that's a rare phenomenon. And so what we've had to do is we've had to concentrate on screening those people who are at risk. And so we've defined that at-risk population. And it turns out that that at-risk population includes diabetics. The two most common causes of kidney disease today are high blood pressure and diabetes. And so if you are in either one of those risk groups, if you have high blood pressure or if you have diabetes, you should be screened at least annually for chronic kidney disease. And that screening should include a blood draw so that you look at a value known as your creatinine. That creatinine test will then be translated into a GFR test, which is roughly a % kidney function. And then you will get a urine screening test that will basically look at protein, blood, or anything else that's wrong in your urine. Those two screening tests are then used to screen people for chronic kidney disease. So we said at-risk folks are high blood pressure, diabetes. If you have family history of high blood pressure or diabetes, or you have family history of chronic kidney disease, those folks should be screened, as I just mentioned. Turns out that if you belong to certain ethnic groups, if you are black, for example, or Afro-American, if you are Hispanic, if you are Asian Pacific Islander, so this would be Hawaiian, those kind of things, if you have that as your background. If you are Hispanic, if you are American Indian, those 5 groups are all at risk. So Asian, Pacific Islander, black, Hispanic, and American Indian. If you're any one of those groups, you tend to have much higher incidence of chronic kidney disease than the white population, actually. So if you compare to the white population, for example, the black population has 5 times the incidence of chronic kidney disease as the white population. The Hispanic population has 3 times the incidence of chronic kidney disease as the white population. Finally, if you're over the age of 65 or you have heart disease or stroke, in other words, what we call cardiovascular disease, those populations are all at risk. And so remember what I said is that recently we said 13% of the population had chronic kidney disease if I just screen everybody. Now if I just take my at-risk population, if I screen those at-risk population, now all of a sudden 1/3 of those individuals have chronic kidney disease. So I increase my chances of finding chronic kidney disease by targeting those at-risk groups.
So if we have one of those patients that comes to their family physician or their internist, and they're screened and they're found to be at risk. Their GFR started to drop a little bit. If I remember right, normal's about 60. So they're maybe now down to 50. It's not a big drop, but it's certainly a drop. Or they're starting to show just a little bit of protein in their urine when we just check a sample. Let's talk a little bit about those kind of patients. What can we do, or what can the patient do particularly, that keeps them from progressing on to some of the things that we'll talk about later?
Absolutely. So if you are identified with chronic kidney disease, so we talked about that. If you have a GFR test, and that GFR test is, as you're right, you are correct, that it's less than 60. If it's less than 60, that's significant. Now, normal is actually 100 to 120. The trouble is our equations don't allow us to estimate that very well. So I get these questions all the time. My kidney function says it's 90. That's too high. Well, that's good, okay? But it's also because our equations that we use to estimate this are not particularly good above 60. So if you're below 60, that is significant. Or if you have an abnormal urine, then that is significant. So if you have chronic kidney disease, the first thing you ought to happen is you ought to have that retested at least every 6 to 12 months to find out what your progression of chronic kidney disease is. You should have your blood pressure controlled. The most important thing you can do to prevent the progression of chronic kidney disease is to control your blood pressure, and we want your blood pressure to be controlled to less than 130/80. We don't want it below 110. Initially, if you would have asked me this question 10 years ago, I would have said lower better.
Yeah.
But we have had some recent studies that tell us that if you get it below 110, maybe not so good, because that may actually hasten some of the changes that go along with chronic kidney disease. If you have diabetes, you should control your diabetes, and we'd like to see your hemoglobin A1C between 6 and 7. If you have cardiovascular disease and heart disease, what you want to do is make sure that you're following up with your physicians on a regular basis and that those diseases are well controlled. We like the use of certain drugs known as ACE inhibitors and ARBs. It turns out that those two drugs have been shown to slow the progression of chronic kidney disease. So if you have chronic kidney disease, and if you have diabetes, or if you have a chronic kidney disease and high blood pressure, ACE inhibitors and ARBs ought to be a cornerstone of your therapy, and your doctor will know what those things are. Low salt diets, okay? Turns out that I can improve your blood pressure control by staying on a low salt diet. That will translate into prolonged kidney function. So what we want to do is we want to try to have you take in less than 2,000 milligrams of sodium per day. That has translated into better blood pressure control. So that's what we want to do. The recommendation is to try to limit sodium intake to around 2,000 milligrams per day. Turns out the general United States population takes in around 3,500 milligrams. So we've got a ways to go. Finally, maintaining a healthy body weight is very important, and you do that with exercise and a good diet. So those kinds of things that help you maintain a good, healthy body weight, like exercise, have been shown to slow the progression of chronic kidney disease. The studies regarding lipids and cholesterol have been a little bit difficult to interpret. Some of the studies have shown that if you control your lipids very tightly, that kidney function will be prolonged. Other studies have not. So that's an inconsistent finding out there. Finally, let me just mention also that I can't reverse aging. Okay, so if I could, you and I'd start medical school again, right?
Yeah, right.
So I can't reverse aging, and it turns out that aging is one of those factors that causes a deterioration in kidney function. So that beyond age 40, we all lose 1% of kidney function per year. So by the time you're 90 years old, your GFR might be down to 50, but that's just because of aging. Aging doesn't cause kidney disease. Aging causes a decrease in GFR of our percent test that we talked about. So aging alone shouldn't be a factor. So if you're looking at your kidney function, always take into consideration your age.
Yeah, and I think that's important to know, because originally we thought, you know, the 80-year-old should have the same GFR as maybe the 30-year-old, and we've learned, of course, that that doesn't work. I think it's important to note, too, Les, that people, some women or men, get kidney infections, quote, kidney infections, which is usually really a bladder infection, that in its own right is not necessarily a cause of kidney disease. It needs to be treated, it's important, but it doesn't necessarily cause things. However, it's been my experience that in some men, whereas we get older, our prostate gets a little bit bigger, we can't empty our bladder as well, and that backup or that buildup of urine in our system and being unable to get rid of it can actually lead to some kidney disease just because the kidney can't work the way it's supposed to. It doesn't push things out the way it should.
Absolutely. So in our ladies, it's very common for ladies to get urinary tract infections in their 20s and their 30s and their 40s. And you're right that does not translate into kidney disease at a later date. Simple bladder infections are common and easily treated, and that doesn't usually translate into chronic kidney disease. However, if it does, then it turns into a different disease that we call chronic pyelonephritis, which means that now that infection that was previously down in the bladder is now made its way up the tube down into the bladder, up into the kidney. And once that gets into the kidney, that infection that we call pyelonephritis, or kidney infection, nephritis if you will, does destroy kidney tissue and can cause a decline in kidney function. In men, as you were mentioning, it's uncommon to see urinary tract infections in men. So if we see a urinary tract infection in men, that's usually plumbing problems. Mm-hmm. And the most common plumbing problem that we see is a blocked prostate. And if that prostate becomes blocked, then any infection that's there is immediately transmitted back up into the kidney as a result of that blockage, because the infection and the bacteria can't be drained out of the bladder because of that prostate. And you're right, that's why one of the risk factors for chronic kidney disease is age over 65, because a lot of guys our age have an enlarged prostate, and that can translate into infection and blockage of the kidney that results in chronic kidney disease.
So it is important to pay attention to those things. And of course, thankfully now we have many new drugs for the prostate so that men can take it that will relieve those and allow them to empty the plumbing better and do some things so that they're less likely to get chronic disease. There are a few rare things that, and at least in my experience, I've seen where people develop autoimmune disorders and some kind of weird things. Those are the ones I always send to you right away because something in their body isn't working right, or there's a protein that's wrong, or something that can have an effect on the kidney, and then those people, of course, get into chronic kidney disease trouble actually fairly quickly, and often a lot younger, at least in my experience.
Absolutely. So we mentioned already that diabetes and high blood pressure are the two most common causes of chronic kidney disease. Turns out that genetic diseases, certain genetic diseases like polycystic kidney disease and others, are the third most common cause. And then fourth behind that is the so-called nephritis. These diseases are relatively odd, and you're right that not many people feel very comfortable with treating them. They're usually the result of your immune system attacking the kidney. Many years ago, even older than I was, there was a Dr. Bright who named those diseases Bright's disease, and so you will still see older folks like us talking about Bright's disease, and that was a generic term that we now think probably was post-streptococcal, meaning as you got infections of either the skin or throat, that you could get kidney disease as a result of that, and that still is seen in children today. Post-streptococcal glomerulonephritis is still seen in children today, and it is a cause of kidney disease over the long course of time. There are other types of diseases, though, that we see, such as lupus, systemic lupus erythematosus. We see certain diseases of the vascular system that used to be called Wegener's, although we don't use that term so much anymore. It's now called granulomatous polyangiitis. I don't want to get too far into the weeds here, but you're right, that if all of the diseases that I've just been mentioning here, their predominant characteristic is that they have a low GFR test and they have abnormal urine. In other words, you look at the urine, there's blood in there, there's protein in there, sometimes there's a lot of protein in there, and when that occurs, those situations require that we commonly do kidney biopsies where we actually take a little piece of the kidney and we look at that underneath a microscope, because it's usually not possible for us to just listen to the patient, examine the patient, or draw a blood test. We sometimes need to take a little piece of the kidney and look at it to be able to make a specific diagnosis that then lead to specific treatment.
Okay, well, we talked about earlier that most patients, especially the at-risk patients for chronic kidney disease, don't have any symptoms at all. However, at least it's been my experience, some of these patients, as their kidneys start to get worse and the function starts to drop, do get into some problems. They tend to have fatigue, for instance, that really tends to tire them out. Swelling maybe sometimes. Their blood count drops, interestingly enough, because of course the kidney regulates our anemia. It's kind of one of those strange things that when I was a medical student, I thought, now wait a minute, this is the kidney, not the bone marrow that makes the cells. So let's talk a little bit about some of those symptoms if unfortunately people don't get the screening that they should have ahead of time.
Okay, so we currently recommend that if you have chronic kidney disease, that you continue to see your primary care physician, just like Dale, and that you have all the treatments that are associated with that. But you're right. If people have a falling GFR, if they have a falling percent kidney function test, and commonly if that test gets below 30, then that's when they probably need to come see us. And that's because they do develop a series of complications that are relatively esoteric and perhaps not something commonly cared for by the primary care physician. And those things are, as you mentioned, anemia. Turns out that the kidney does indeed make a hormone that helps make blood counts, and that as your kidneys fail, your hemoglobin gets quite low. It may get less than 10, and in those situations you feel fatigued, you don't feel well, you have difficulty sleeping, you have exercise intolerance. There's a term we use called lassitude, which just means I don't feel like doing anything at all. And those folks can actually be helped with the administration of, we now have that hormone available for administration in our patients where we can actually improve the hemoglobin count as a result of that. There's other diseases that occur when the GFR gets below 30. And those diseases include bone disease and arthritis, so that there are certain glands in the neck that we call parathyroid glands that become activated as a result of the kidney disease. And those glands then can, the hyperfunction of those glands can result in arthritis. They can result in skin lesions and itching. They can result in a number of different complications, and those need to be effectively managed. They also result in a deficiency of vitamin D. So we frequently measure vitamin D in our folks because the kidney does make active vitamin D, and that's part of its function. So as the kidney continues to deteriorate, we see these abnormalities. We see the fluid retention that goes along with that. So many times we'll have to use some very potent diuretics to be able to counteract some of that fluid retention. We still rely on diet. Diet is very important, and we have dietitians who work with us in our office with that, because kidney diets are very specific and very complicated. And so while it's true that most physicians can go out there and teach you to be on a low salt diet, or at least talk about some of those things, the kidney diets that we use are very specialized. And so what we use in that situation is a dietitian to help us, because what the dietitian does is then go look at the blood chemistries, learn the blood chemistries, and then recommend a specific diet based upon what those chemistries are and the percent of kidney function.
And sometimes all we're doing is trying to prevent it from getting worse. We don't necessarily bring it backwards. Unfortunately, this seems to be one of those kind of downhill things that as people, for whatever reason, progress downhill, we can't just kind of reverse it. It's kind of like that aging process. It just kind of keeps on going whether we want it to or not. So it really is significant and important for those people. And I know some of my patients, they kind of resist. Well, I know that we sometimes have to restrict protein or something, but I still like to have my hamburger and my steak and all the other things, and we have to kind of lean on them, because if they don't, they start to get in trouble pretty quickly with some of these things.
And our dietitian listens to what they do. So what they do, the dietitian listens to what they're eating and then tries to make adjustments in that. We don't try to say no to this or no to that. What we try to do is say, let's listen to what you're doing in your diet and then make adjustments accordingly, so that we can try to limit and change some of those characteristics that are commonly causing symptoms. Now, as the disease progresses, and you're right, it does, unfortunately, and most kidneys, by the time you get the GFR under 30, it's going to fail at some point. We don't know when, and sometimes it fails when you're quite elderly and you say, I don't care. If my kidneys fail, so be it. I'm not interested in sitting in a dialysis chair for the rest of my life or doing any of those kind of things. And I'm beyond the age where transplantation is appropriate. But for anybody else, what happens is as their GFR declines to less than 30, we will commonly get them into our practice, and we will see them fairly frequently so that we can start planning for their dialysis. We can start planning for their transplantation. Turns out that when the GFR gets below 20, then I can actually get people on the transplant list and be evaluated for the transplant list. So they can commonly get transplanted before they go on to dialysis, as long as we can manage all of the other complications. And so that's why I said is that most primary care physicians will be able to manage people early stages of kidney disease with GFRs above 30. By the time you get below 30, and especially when you get below 20, that's when complications do ensue, and we're going to start talking to those folks about dialysis and transplantation.
Okay. Well, we talked about, of course, the importance of medications early on if you're at risk for kidney disease to get your blood pressure down where it belongs, and the fact that we do indeed have more strict normals, or strict, this is where it should be, for those kind of patients. We also talked about the importance of getting that hemoglobin A1C, that average blood sugar test that we use all the time for diabetics, down. Are there some other medicines that you all sometimes use? In addition to those medicines, are there some medicines that will help maybe slow the progress a little bit? Since we talked about it isn't going to go away, at least we slow it down.
Well, yes, and we've known that, for example, that treatment of the anemia will result in some slowing of the chronic kidney disease. Treatment of the blood pressure will result in slowing of the kidney disease. Treatment of lipids under most circumstances does, but there are situations where that does not occur. We commonly use active vitamin D to be able to prevent some of the complications of chronic kidney disease as well. Now, in patients who have nephritis, that's the one area where we can, if someone does have a nephritis and an active inflammation of the kidney, yes, we can use prednisone. We use other types of agents to be able to slow the immune attack on the kidney. And so those agents are used to help slow the disease and in some cases reverse the disease. For example, I have certain patients who have a disease known as scleroderma that when in my practice, scleroderma, when I was in first training, was a lethal disease. And many patients died. Now, with appropriate treatment, I can reverse that disease. And I had several patients with scleroderma come off of dialysis. So, yes, but it requires a specific diagnosis. And so, as I said, when somebody has their GFR below 30 and you don't feel comfortable managing them at that point, then it's common for them to see us so that we can either make an appropriate diagnosis or make a specific diagnosis and then recommend specific treatment thereafter.
And I think it's important to note that these particular patients with any chronic kidney disease really have to be careful and really need to check with us or with you about any other drugs that they take. As we get older, we've got a joint that hurts, or we overplay racquetball and we've got a couple of joints that hurt, or whatever it might be. And our tendency, of course, is to go home and take some ibuprofen or some naproxen or some other medicine, or our doctor may put us on some other medicine that is, quote, better, but really doesn't protect the kidneys. So it's really important to be very, very careful with people with chronic kidney disease with any of those kind of medicines so we don't get in trouble.
Absolutely. Well, it turns out that the kidneys are responsible for eliminating most of the drugs from your body. And so as that kidney function declines, that's the other thing we tell our patients when we're seeing them in the office is if somebody puts you on a new medication, it needs to be dosed to your level of kidney function. And so that dosage for example, antibiotics and for many other common medications, heart medicines included, have to be adjusted for the decreasing kidney function that occurs there. And you're right, non-steroidal agents are just very difficult. It is true that they're wonderful agents for relieving pain, but they also take all of the protective mechanisms away from the kidney, so that drugs such as ibuprofen, Aleve, Advil, naproxen, all of those agents, Toradol, naproxen, all of those agents are wonderful arthritis pain medications, but they take and they actually directly decrease kidney function, and they occasionally have put people onto dialysis earlier than they should have been, just as a result of the administration of this drug in a situation where perhaps the kidney was at risk.
Okay. Well, and we've talked about the fact that when we ultimately don't make success, we end up with dialysis, or certain younger people will actually end up with kidney transplants. I know from my experience that there's always many more people who need the transplant than we have kidneys that we can get. But there's dialysis, which basically involves finding a way to remove the poisons, if we can use that term, that the kidney normally gets rid of, and get those out of our system. Otherwise they build up and cause problems. So I know you do a lot of work with dialysis and then ultimately with transplant. So in the last minute or two, let's talk a little bit about those sorts of things, because they are significant for, again, an increasing number of our patients.
I just checked yesterday, and there are 117,000 people waiting on the kidney transplant list, and last year we did 17,900, around 900 kidney transplants. So there are a lot of people on the transplant list waiting, and so one of the biggest things we want to impart to people is to be an organ donor. We have lots of people who are dying on our list right now and trying to get a kidney transplant. Some of those are getting kidney transplants from their relatives, and we call those living donors. Now, as far as dialysis is concerned, we have basically two forms of dialysis. One is blood dialysis, and that's where you come in and sit in a chair for 4 hours 3 times a week. Or we have another form of blood dialysis where we go home, and rather than 4 hours 3 times a week, it's about 2 hours 6 days a week. Same number of hours, we just make it shorter so that you don't have to sit in the chair so long. And then we have another form of dialysis where we teach people how to put fluid into their abdomen. That can be done at home. So both blood dialysis and the peritoneal, or the stomach dialysis, can be done at home. We teach people how to do it at home, and in a rural state, turns out that our practice has the highest population of home dialysis in the country. So if you look at our practice as a percentage of how many patients we get at home, we get the gold star for the highest number of patients at home. So we would like to get you at home for your dialysis if at all possible.
It's a difficult thing, and certainly it limits people's lifestyle, but it's what we have, and it does work, and it does help, and it does lengthen their lives. So we appreciate that. Well, thank you again, Dr. Spry, for visiting with us today about chronic kidney disease. This is Dr. Dale Michels from the Lancaster County Medical Society, and this has been Talks with Docs.